Next, I would like to introduce Dr. Peter Goadsby, who you've seen quoted or cited in a number of presentations, and he's going to speak on dispelling myths about visual snow, and he's also going to give us a progress report. Dr. Goadsby.
Well, thank you. Let me slide. Good. If you wonder, the little image on the left down at the bottom, that's not visual snow, because all the images have been about visual snow. So I thought I'd have an image that wasn't about visual snow. Why not? Could break the mould. It's just one of those Hubble telescope sort of pictures, but I think they look quite nice, so I put one on one of my slides. Let me start by thanking Paul and Sierra. It's quite extraordinary to me, I have to say, to be talking to so many people who are interested in this subject. I acutely remember the first time I spoke about the subject to colleagues, and they weren't interested at all. They're actually a little critical, you might say. So it's quite nice to have got a group of people together who are actually interested. That's quite cool. And I mean, it's extraordinary that this is happening, I have to say as well, given the relatively short period of time that research in this area has been getting organised. I'm going to go through some of the things we've done. I'm still amazed that we're here. When Paul said he was going to organise this last year, I thought, like, okay. But he did. That's amazing. So thanks for that. So what am I going to babble about? I think that when I came to the questions about visual snow, I think there were 4 things that struck me as I saw patients who mentioned this problem. The first, and these are the 4 things I want to deal with. The first one was that the condition didn't exist. That seemed implausible because the people were there, but nevertheless, that was, that was one of the views. One of the speakers already mentioned this. Certainly, there was, it still is, quite a strong view that patients with the problem are just crazy or a little crazy. Matthew probably reaffirmed that for you this morning in his presentation, so I probably won't go into that one. He's made it weak for me. The third one is that this is a type of migraine. That's why I got sent patients, and I think it strikes anyone who's interested in migrainology that that's just nonsense. But nevertheless, that was a view. And the other popular one is that it's all due to illicit drug use. And I have colleagues who really, really head up on this subject of illicit drug use. And it's not all due to illicit drug use. I sometimes wonder whether people make that judgment because of their own past behaviour rather than any sort of projection, you might say, but I'm not going to go too far about that. One of the first pictures I ever saw of visual snow is a slightly primitive picture done by a child on a computer, and I think one of the things which got me really interested in it was that children describe it exactly the same as adults, and children have a wonderful frankness about them. They've got all sorts of explanations for what's going on, but they do have a wonderful frankness. And it's hard to walk away from a syndrome that, as also one of the speakers said, it's just the same everywhere. Everywhere you go, if you ask about it and listen to what a person says, they more or less say the same thing with some twists, of course. They say a core thing. And I think that's why our colleagues interested in physiology and anatomy are attracted a little bit to this because there's clearly a pathway thing going on in the brain. I'm not going to draw too many of those because you've seen a few of those already. This is one of the earlier, more elaborate diagrams that a young fellow drew for us and that we published on. This goes to the condition does not exist. I think it's very difficult to escape a condition that's so universally described. And this child's describing, obviously, the entoptic phenomenon and palinopsia and describing his floaters and such things. Lovely picture, really. Better than I could draw. That's certainly the case, but because I can't draw at all. I don't have any particular life skills. We're probably going to work that out as time goes on. I just sort of do one thing. So we published on this just to try and get some traction in the paediatric literature. It must be horrible for a child to have something like this and be ignored or told they're crazy or kind of just told it was wrong, because it must be hard for children when they know something and their parents just tell them they're wrong. It's very, very difficult. So when we came to the problem, it was well recognised at some level, I think. Grant Lew had described in Neurology in 1995 a series of cases with persistent visual disturbance, and at some level it was the first of the descriptions of what's come to be called visual snow, but it admixed migraine, and that's a real problem. Putting them together has caused part of the problem, and there's some interesting stories around that first paper. What's clear is that the core thing is this continuous pan-field disturbance, which is dynamic, put it like that. And when I first became interested in it, the differential diagnosis was persistent migraine aura, because I'm a migrainologist rather than a neuro-ophthalmologist. I'm a neurology-trained migrainologist with all of the neurology baggage that Owen described, although I was trained by someone who was remarkably flexible, so that I was lucky like that. There's the post-hallucinogenic ideas, and of course emotion and anxiety is a nice way to say people, you think they're crazy, but couch it in terms that can be acceptable. So what we did at the start was first thing I did was to go and dig into the there reaches a point when you see things where you either do something about it or you just shut up. And it struck me some time ago that it was time to do something about it, because it's just nonsense to keep hearing the descriptions and not having anything satisfactory to say. So just irritating. So to start with the irritation, we looked back on 10 years of patients that I'd seen, 38 patients, of which 22 had a really detailed history. I'm grateful, particularly at that stage, with working with the Ion Vision people who helped us with providing initial cohort of patients, and really helped our interactions, the research group's interactions with you guys who've got visual snow. So what we did was what the computer people call bootstrapping. So we took my clinical experience, looked at what was the core features of that, wrote them down, and then tested them on a group of patients from Ion Vision, saw what the themes were, and then retested that on another group by direct patient interview. And this is where Christoph Schanken started to work with me. He's a German fellow who came to work on migraine. And we were doing some other imaging work, and I said to him one day, could you work on this, because it's going to take you a while to do the imaging, and this is sort of tricky, but it requires a certain disciplined mind. So naturally working with someone of German extraction provides you with a disciplined mind, and he's a very disciplined chap. So he did the direct interviews, and we wanted to then propose working criteria that we could use moving forward. And these are the pictures from that paper, the sort of appearances that people have trailing the moving objects and this pan-field visual disturbance. Of the first 120 patients we had with these dots, they were 30-year-olds, more or less males and females. About half of them had the black and white dots. These are intersections of those things. And we looked at interview for the various symptomatology. And the way we came to the criteria was simply we're not trying to cover everybody. You don't want to cover everybody when you first derive criteria for something. You want to cover a very core group which are the same, because if they're very similar, it's much easier to do research on that group and compare it to a very different group, a control group, and look for the distinct differences, and then expand your initial core group. If you start taking everybody at the start, well, look in the room. You know, there's people here look a bit odd, I have to say that. Me. And, you know, no one's got the same clothes on. Everyone's got clothes on, which is a mercy in San Francisco. There was a referendum some years ago about whether it was what part of your inalienable human rights to go naked in the streets, and it only lost by one vote at the council or something. It's like, really? Whatever. I mean, you probably appreciate if you walk around the street anywhere that you need a certain core. If you take everybody, it gets a little difficult to do. Anyway, that's why we sat with these symptoms and worked out what was more common than not, which is not to exclude the other symptoms and say they're not part of the problem, but simply that it makes it too hard to study. And when you're starting something, you really have to be very focused on how you do it. So we looked at, we found, and we grouped them together. So the palinopsia things, these entoptic things, and these the more migrainous ones, the photophobia. And we came to these criteria of continuous, which you've seen. 2 additional symptoms. Why 2 additional symptoms? Well, to tighten up the group. And it's not to exclude people to say you're bad, but it's simply to try and make sure the research we do is as tight as possible. You have to appreciate that, and you probably do appreciate because you've all been battered by various physicians, that not everyone thinks this is a cool idea, and not everyone thinks it's even a thing. So if you're going to develop something, you have to be a little bit holier than the Pope, you might say, with all due respect to any religious thing, and I've done enough courses to know that was a stupid remark to make, so I sort of withdraw it. I couldn't think of another analogy, unfortunately. Better off not saying anything. I've learnt that. So what we're trying to do is make a, let's say, homogenous group. That won't get me out of trouble. That where the symptoms are certainly not typical of migraine aura, and they're not attributable to another disorder. That's a way to get rid of hallucinogenic drugs and such things. And one of my clinical fellows prefers a slightly more engaged picture there of trailing than the one that I already showed you. We took those criteria, tight criteria, and then asked ourselves the question, well, what's a way of getting people on board with this idea? And a way of getting people on board is to measure something, so speakers have been saying, that has an objectivity to it that's difficult to argue with. And brain imaging is very seductive in many ways, particularly in the neurologic field. I want Victoria to appreciate this. If you show neurologists something in the brain with a little dot on it, they think, yeah, okay, that's in the brain. They go, fine. Although, of course, there's a lot of processing to be done in functional imaging, but it really helps people get on board. So what we did was this study, which we did with the eye and vision people, and very grateful for that. We got patients with visual snow, but a very restricted group who fulfilled those criteria. Where I wanted to take a group of people where if you went through the histories, you'd all say, yeah, okay, they're fine. They're not everything, but they clearly had that core visual snow problem. And we looked at something called deoxyglucose metabolism. So the brain requires glucose for its basic metabolic fuel. You can label a form of glucose that only gets processed and then stops in its processing. And what you can do is look at with an appropriate scanner at the accumulation of that deoxyglucose in the brain. We did the studies down here. This is PET, positron emission tomography, so it requires a radionuclide. It's a bit fancy to do it, but it's an established technique, and it shows how much glucose or how much metabolism the brain is using. And what we found was was that a particular area, the lingual cortex, already been mentioned, is more metabolic, more active in people with visual snow than controls. And it's hard to argue that that's not a thing, because that is a thing. What it means, what the implication is, whether that's actually the important area or that's a consequence of something else, that's an open question. But the fact that there is a thing is the thing. And that's been helpful for getting many of my colleagues to buy into the idea that there probably is a thing. Or this is the centre of craziness. That's the other option, which would be perhaps more interesting in many ways. But, my psychiatry colleagues would have a field day with that. But I think it's a thing. It's not just the craziness thing. What we've been doing recently, Francesca Paletta is going to be presenting this at a neurology meeting in Europe next week. So this is just to give you an idea of the kind of things that we've gone on with. We wanted to get a decent collection of patients to reinforce the thing. So I like round numbers. We're like about 100 if I want to do something usually. But for visual snow, I thought we needed 1,000. Because if you want to really get people to get on board with something they don't like, you want a number that's so big they go, okay, a crazy person, but fine. And 1,000 struck me as that sort of number. So Francesca's been beavering away with the help of the Visual Snow Initiative on this data, which we've collected, as you can see, from pretty much all over the world, with a predominance of North America and Western Europe. About 30-year-olds, female to male ratio is hanging out as about 1:1. Look at the onset of visual snow, mean of 13, and for about 40% of patients, they remember it for their entire life. Entire life. This is it's a very, very nasty thing to think about it in that way. 17 years of disease onset, some worsenings, and we looked at onsets and around episodes of migraine, trauma. Look at the onset with medication. It's not that big. Blaming medications for this, in the main, is probably not the answer to things at all. Most people with a sudden onset have no apparent cause. We tend to attribute if we can. I think it's useful. The nice thing about starting to get bigger data sets is you can start to get rid of noise and understand what the core messages are. And there's quite a lot of work to do, obviously, you probably appreciate, to get detailed information on this many people. But I have this sort of vision of building up the size of things, and every time you increase the quantum of it, you get rid of more noise, if I could say that, and you start to focus in on the things that are really going to help us understand the problem. These are the sort of, many of you will be familiar with these, of course, because we will have them, the classification of the kinds of disturbances that we see, the coloured, black and whites, the flashing static, and then the transparent static. And people have anything between one and all types of these. Most patients will only have one. Why are we doing this sort of, why do this kind of thing? Because if you want acceptance in a condition, you have to provide very detailed phenotyping information for physicians. And they won't remember it all, but they'll remember. My mission is to make them remember there's a thing. And a lot's known about the thing, so all they have to remember is the name, and they'll start to make the associations. It's very important in physicians' minds. These are the associated symptoms from the first study. We wanted to look at how they lined up from our first brain paper into these current 1,000 patients. And, we did pretty well, I think. Most of the symptoms have lined up within any sort of reasonable range, as you can see. Someone's talked about tinnitus already, and it's true that about 3/4 of patients have tinnitus, and it does seem likely that there's some very comparable pathophysiology going on in tinnitus. It wouldn't surprise me if there was a tinnitus problem, which is more or less identical to what we're talking about. And as Owen also suggested, we'll learn a lot about the brain from understanding these things. This is the migraine associations. There's no doubt there's a comorbidity here. Migraine is very common in people with visual snow. They're more likely to have the after images and photophobia. Well, that's not entirely surprising. And a range of things here are all more common in patients who've got visual snow and got migraine. Question is whether... I don't have an impression that visual snow is more common in migraineurs, people with migraine that I see, but certainly in visual snow patients, migraine is more common. What is that? I wonder whether it is an interaction of two unpleasant things in a way, in the sense that if you have a visual disturbance and you also have migraine, which is an inability to habituate to the sensory environment, you might notice that visual disturbance more easily. I think it's an interaction of the two conditions. I don't think the conditions are equal conditions at their core, but that's an opinion. These are the data. We have to be driven by opinion. I think we can agree the condition exists, and that not everyone's crazy when they're describing it, simply because these numbers continue to pan out, whether it's 100 in the first series or 1,000 in our new series. I mean, it is what it is. It's very hard to think that there's that much shared craziness in the world, although one looks around sometimes and wonders about that with our political masters. Is this a type of migraine? This is where I came to it. So people with migraine describe this for their typical visual disturbance: a jagged, straight, bright line that will move around and enlarge, and as it enlarges, leave a loss of vision behind. So the outside bit's called a fortification spectra because it looks like a fort. Okay, these are 17th century forts. The Europeans used to build them because if you have sharp edges like that, you can shoot people from both sides. They're very efficient, apparently, for killing life. At any rate, this is where the terminology comes from, and the thing that's left behind is called a scotoma. It's nothing like what people with visual snow report. This is what a psychologist plotted his visual aura, a guy called Lashley. He was described as an obsessive psychologist. I don't understand why they need to say obsessive. He's a sorry. I couldn't lead with that. So he's described it, and what happens is that there is a change in brain blood flow that moves across the brain. It's illustrated by those lines, very slowly, 2 to 6 millimetres per minute. You can see it with all sorts of imaging modalities, and here is an example, someone I saw, actually I was visiting a laboratory with, and you see the bottom right there where the blue bit, there's this reduction in brain blood. It's a very characteristic finding. It's been used, a number of imaging modalities show that, PET, this sort of imaging, functional MRI imaging, all will show the same thing in that. But if you look at visual snow, it doesn't do that at all. We looked at patients several years ago, 10 years ago now, looking at their diffusion maps, was how water moves through the brain, and blood flow using an MR technique, which is pretty primitive at the time, I have to say, and didn't see anything like what you would see if you see someone with migraine. So the phenotype, the description is nothing like migraine, and the physiology, so far as we've seen it, is nothing like migraine. So I come to the following conclusions, and I show you another little picture down there. Little fella asked to draw, I think it was his aunt, and draws his aunt. Not quite as elegant as the last one, but pretty cool. And then all those little dots. Where did he get that from? Where does a 5-year-old get that from? Except they got a genuine problem. They don't make that up. This condition clearly exists. I don't think patients describing that they're just not crazy at all. We're all a little crazy, it is what it is, but it's not the basis of the problem. It's not a type of migraine. There's nothing that points to that. The phenotype doesn't point to it, the physiology doesn't point to it, doesn't behave like that. It may coexist with it, but doesn't behave like that. And it's not simply due to illicit drugs. So I didn't say to you, but we've excluded people, with all due apologies to them, who've used illicit drugs in our studies. Why? to answer this very question, because if we'd included them, we'd only been pilloried for doing it. And it's not to show any judgment about it, but simply to try and get rid of some of the nonsense around it. You have to do that. It's a real problem. It's a problem that's predominantly in the brain. I illustrate the area there again because it's been helpful for the work. I think that going forward, this initiative that is really kicking off today, if not for someone picking the ball up and running with it, nothing will happen. But there's such an opportunity. I'm a little more optimistic maybe than many, because I've seen this go from nothing to a thing in a very short time. And this condition's of its age. It's ready, and the technologies are available to dig into it and understand it. There's such an opportunity. I have to say, on behalf of Neurology, let me apologise to you if we as a group have ignored the problem. And let me assure you, however, that there's an optimistic tone in this, that things will get better, not because we're just sitting around talking about it, but because we're doing things, and with all your assistance, one day we'll get there. Thanks very much.